Welcome to an international perspective on the role of point-of-care testing in disaster management. This is Dr. Gerald Koss speaking. This lecture, which really is more of a workshop because we have a lot of work to do, comes to you from the Point-of-Care Testing Center for Teaching and Research at the University of California, Davis. The second slide gives our global goal. And in this case, we really should be thinking globally because of the way natural disasters and other calamities occur around the world. And that is to improve and harmonize point-of-care national disaster caches. As I mentioned in an earlier lecture, it would be virtually ideal if we had some common operating principles, common training, access to training via web, which should be free, by the way, and if personnel, along with the devices and tests that were used to respond to these disasters, were somewhat uniform worldwide. Of course, that doesn't mean that we can respond uniformly, but instead we'll present a concept of having a point-of-care disaster cache and then a customized one. Customization is particularly important for infectious diseases as they're cropping up in different parts of the world and require targeted, focused responses. Well, the workshop objectives are to introduce the fundamental operating principles of rapid response and error prevention for point of care. As I said in the earlier lecture, point of care testing is not an excuse for inaccuracy. We want to maintain very high levels of performance. Next, to assess and reformulate point-of-care technologies in the United States disaster caches, thereby facilitating the same sort of actions in other countries. To explain the significance of limited detection, LOD, the 99th percentile of normals, and the 10% coefficient of variation, CV, for cardiac troponin I testing. To position point of care correctly when in challenging settings, and to develop an enduring guidelines and policy framework for the future in order to accelerate global harmonization. Let's launch into our first workshop objective, number 1. It is to introduce the fundamental operating principles of rapid response and error prevention for point of care. This will be a review for many of you. Slide 4 shows that we will take a macroscopic viewpoint looking at global system goals, system objectives in the form of minimizing morbidity and mortality, and then system objectives in the form of enhancing diagnostic and therapeutic performance. In the central circle, we see that a regional center can support the community with various modalities of care applied to primary and home care, possibly through telemedicine. And then in the acute care arena, point-of-care testing can facilitate that by being used in the ER, the ICU, patient-focused care centers, ambulatory care, children's hospitals, ORs, and the clinical laboratory. Remember, for many low-resource settings, the community hospital clinical laboratory uses point-of-care technologies by default, as it is too expensive for them to purchase mainframe chemistry analyzers, and many of them have no blood gas analyzers, or what we call nowadays whole blood analysis, with which they will do PO2, PCO2, pH, and electrolytes simultaneously on one relatively conservative whole blood sample. Then moving around the scheme clockwise, we really do want to optimize knowledge, and there we can have several functional targets such as our information systems, our PDAs, that is something like the wireless technologies of the iPhone or other connectivity devices that we hope will be integrated with point of care in the future. Care paths such as the one I presented for diabetes in the previous lecture, and so on around, attempting to optimize our outcomes with active management. So this boils down to the community, acute care, and then integration and synthesis of these functions as we operate somewhat in the modern cloud of connectivity if we have that privilege. Slide 5 goes back in time. It presents in the upper frame the concept of therapeutic turnaround time, which includes the red and the yellow blocks. They represent, respectively, test ordering to results receipt, and then the next time interval, results receipt to treatment. In fact, that is TTAT, and we hope by shortening TTAT, as portrayed in the bottom bar of red, yellow, and green, that we'll also shorten the time to a desirable outcome. And generally speaking, people appreciate having convenient and fast testing delivered by whole blood analysis and point-of-care technologies. And you can see that we, for the most part, will shorten the time frame to just a few minutes in the order of, say, 10 or 15, possibly even seeing a desirable outcome in that time frame. The next slide comes from a paper published in Clinical Chemistry, where basically the authors showed that therapeutic turnaround time was a valid concept, and in relation to it, point-of-care testing was particularly effective in reducing TTAT. Point-of-care was useful overall and in terms of accuracy and the opinion of the users in the CICU at the bedside. And the evaluation correlates that statistically made up most of the weight of these performance enhancements were timeliness, convenience, labor conservation, and improved patient care. The next slide shows you the concept of getting our whole blood analysis done by means of activity-based biosensors that deliver several simultaneous multiplex test clusters with appropriate accuracy, rapid response for critical indications at the point of care. And I mentioned, while it may seem like medieval history at this point, actually a fundamental shift in point of care occurred when electrolytes and metabolites were combined with blood gases and pH on whole blood analyzers. Slide 8 then presents the concept of multiplex measurement, where we will basically look directly at an anaerobic biopsy of the blood and produce activity-based analyte measurements that are highly relevant for managing the patient. The next slide is a scheme devised by others that shows the pivotal role of blood gases, hematocrit, hemoglobin, our electrolytes, glucose, and so on in maintaining the life chain, if you will, from oxygenation through the lungs, through the erythrocytes that carry the oxygen to the heart and brain, and then provide the basics for metabolism. And of course, we want to also look at analytes like lactate and the general environment of sodium and pH in order to assess patient status. Lactate in particular is used as a marker for sepsis in the emergency room and should be part of our repertoire in building a disaster cache. Slide 10 summarizes this further at a little higher level in terms of temporal optimization on the left and diagnostic therapeutic process optimization on the right. If we can deliver both of these, we capture the physician at the bedside. That is a singular advantage of point-of-care testing, and if it's not the bedside, it could be in a disaster setting or an alternate care facility where we provide similar services to the victim. But we're talking about a frontier when we discuss delivering a complex list of tests at the site of need in disasters and complex emergencies. We really do need to develop evidence that point-of-care testing is cost-effective, efficacious, and efficient in those settings beyond what we have now. But extrapolating from the functional attributes on the left, fast therapeutic turnaround time, and integrated modalities of testing, and adding those with test clusters, rapid diagnosis and treatment, and information connectivity on the right, we can be reasonably sure that when we implement point of care, that is, well-selected devices in the disaster setting, we will bring about a change that is going to improve outcomes and has significant impact. Nonetheless, we must do this, as you see in slide 11, following the total quality principle for point-of-care testing. For the United States, which is the context in which I drew this concept up, we think of this based on the concept of site neutrality, and we integrate quality control, quality monitors, and proficiency testing into one patient-focused package that meets customer needs irrespective of where testing is performed. You might say this is the quality bottom line. Slide 12 shows the basic features that should now be on every point-of-care device that is used for critical decision making in terms of security, validation, and performance, and additionally incorporate safeguards and connectivity when reporting out point-of-care test results. We didn't always have PINs and passwords for the operation of point-of-care devices, but we should even in disaster settings. The merit of overrides and other compensations that would allow just anybody to do testing can be argued, and in fact, for our national disaster caches in the United States, which, by the way, are under one CLIA license, it is necessary that people are trained, that they have credentials at the time they open disaster caches, that they first perform quality control before doing anything else, and that, in fact, they're competent to use those devices. In the next Venn diagram, you can see that when we supply security, validation, and performance in an integrated package, this will help prevent errors. And indeed, wherever we do the testing, irrespective of the site, we definitely want to prevent errors and reduce risk in using these technologies. That is a review of our basic approach. I think this will be perpetually part of the legacy of point-of-care testing, but each and every one of you listening, I hope, will carry forward these fundamental principles as we now move forward into the arena of disaster caches. Workshop objective number 2 is to assess and reformulate point-of-care technologies in the United States disaster caches, thereby facilitating other countries. Please bear in mind that this is a work in progress, and we encourage all listeners to help us with fresh ideas about how to constitute the disaster caches, use those devices appropriately, and harmonize them on a global basis. Slide 15 shows the current so-called lab basic, which is in a container less than 50 pounds in weight, and you see the sorts of devices and tests that are available. Rather than discuss each of these in detail, I'm going to focus on the particular test that is available for cardiac troponin I qualitative testing that you see in the upper right. In fact, we know that in disasters, people will develop chest pain for a variety of reasons, and we have anecdotal evidence that responders, even in Hurricane Katrina, wished they had had some way to determine whether there was acute myocardial infarction associated with the chest pain. Slide 16 presents the value proposition then for point-of-care cardiac biomarker testing. Remember, please, as I discussed in the first lecture, we will persistently and consistently try to attach value to what we put in the cache and how it will be used to help in critical decision making where the victim needs it the most. In this case, the right pathway you see of going from the yellow circle of the laboratory out through a long protracted series of transport, analysis, and reporting with many delay penalties just won't work. To establish value for the victim and then patient, we really do want to use point-of-care testing in order to produce fast treatment and management decisions. Call it triage if you like, where we integrate results and then synthesize value to turn our circle of problem-focused strategy in the small world network. Then we must dig into this with workshop objective number 3 to understand and explain the significance of limited detection, the 99th percentile of normals, and the 10% coefficient of variation for cardiac troponin I testing. Slide 18 shows you a variety of devices that are available. The one on the top left is already used in the U.S. disaster cache. The one on the top right is an exception amongst all these. It is not available in the United States, but I mentioned in the first lecture it is used widely in Asia and South America. And then the other devices would fall into the category of portable or possibly near-patient testing. I don't mean to suggest that any of these, except the simplest and smallest, become part of our national disaster cache, but instead I'm trying to focus next on the ability of the devices to actually rule in and rule out acute myocardial infarction. Slide 18 shows you the lineup of limited detection, LOD, in nanograms per liter, which is the current accepted unit base for cardiac troponin I measurement. And you can see that, in short, we move from a definitive technology on the top to the very worst of the lot at 1,500 nanograms per liter, qualitatively detective, which means yes or no, on the bottom. And in fact, the one on the bottom is the one that is currently in the U.S. disaster cache, and we feel that this kind of information shows it should be replaced. Until something very much better comes along, we can provide cardiac troponin I testing with the iStat, and we just have to understand that these devices, while they're convenient and handheld, small, fast, and produce the results we want, are somewhat of a compromise in terms of limited detection and the other key parameters by which we assess modern cardiac troponin testing. Slide 20 summarizes those parameters for you. You can see that for one device on the left, all three of the LOD, 10% CV, and 99th percentile are clustered nicely in the location where they should be, at approximately the 99th percentile of cardiac troponin I for healthy subjects. And this information is drawn from references we're happy to supply you with. Then to the right, we'll see how the current device in the disaster cache lines up at somewhat of an intermediate zone, and on the far right, the unacceptable qualitative cutoff of the test that is being used. In regard to the x-axis, please note that it is broken in several intervals and that it is not linear. The cardiac troponin I goes up virtually orders of magnitude as you move from left to right on that axis. Well, we have a candidate then for the new disaster cache, and that is a more sensitive cardiac troponin I test. Now let's look into the Lab Plus package, which is up to 400 pounds and sits on a pallet, has to be moved by machines, and includes a couple very large devices, one of them which, in our humble opinion, doesn't seem suitable for this because when it sits, that is the hematology analyzer you see in the bottom left, when it sits in the disaster cache warehouse, it doesn't really want to do that. It wants to be operating every day, functioning, and it therefore requires a lot of maintenance, which probably result in cost inefficiencies which we can eliminate. Let's look at a potential new hematology device. Now please bear in mind this is not FDA approved. It's considered investigational, and it is simply a little bit of thinking out loud, but has high merit as it is small, roughly the size of a small toaster, and flow-based, and will provide a palette of not just hematology tests, but other chemistry tests as well. Slide 23 shows you the flow operating principle. On the right, the microfluidic flow control through channels sandwiched between two plastic plates, and on the left, a suggestion that a CBC can be achieved in just 3 to 5 minutes. And this technology, using plastic plate cartridges for testing, is rather inexpensive. Let's look at the next slide then. What we're going to emphasize as we design our disaster cache, and I hope you will consider this a workshop and investigate what your country has, what the potential for its use is, and then what value it has, assessing the total sum of benefits minus costs. As I suggested in the first lecture, critical information has value exceeding the cost of the test alone. Physicians assign high value because test results impact decisions. Nurses assign higher value than laboratorians, and speed has value, often life-saving. Patient self-care and responder welfare garner value as well. When we add this all together, we get a total value equation that depends on the sum of benefits minus costs. Simple as it might be, this is a philosophy then behind the cash that we have suggested, and we have currently, at the time of preparing this lecture, put this paper into circulation and will soon submit it for publication. Slide 25 presents then a disaster point of care cache, which we feel can go into one container up to 70 pounds in weight, which we deem and others deem acceptable for use by disaster medical assistance teams, DMATs, in the United States, and for use globally in worldwide response. These are all small point of care devices. We have put the hematology analyzer in here. As I mentioned, it's about the size of a small toaster, actually a little smaller. We have included in the top left a device that is already in the cache. It's wireless though in this case, and it will do cardiac troponin I testing. In the bottom left, we want to have that min-max temperature readout, because if at any time the temperature in the box when it's transported falls above or below what manufacturers specify, the reagents really should not be used. A degree or two may not make that much difference, but again, that's why we do quality control testing as the first step before using the devices. And we have included several other technologies here, some which have been sorely missed and may be available from various sources, but not necessarily all in one box, such as the HIV testing. And please bear in mind that HIV testing is necessary to protect responders as well as victims in the event of inadvertent needle sticks and exposure. Under the stress of disaster work, needle sticks are unfortunately more frequent than one might anticipate, and therefore we see value in adding this to the basic cache. Then we have selected other devices such as the glucose meter mid-bottom that provides a very relevant set of measurements that have now proven their worth in a hospital context. We've also included monitoring devices, and next to the pulse oximeter that I mentioned is actually the sort of model used in the Phang Nga province tsunami experience. We add Wi-Fi indicated by the symbol there, as we would love to have all of these devices connected to a common modality of information and knowledge processing. This would be the basic disaster cache. It is expanded in function considerably from what the United States currently has in the most basic box, but to it we're going to add, as the next slide shows, slide 26, a concept of customization for decision making. With consideration of the fact that a variety of different disasters can occur, including pandemics, which are threatening us now at 2 places in the United States with the new H7N9 virus and SARS-like coronavirus. We have to have a concept of flexibility, and in the cases that we use instrumentation that might be a little large, a little awkward, or not environmentally sound, we also have to think of supplying an alternate care facility, as you see listed toward the bottom, with a variety of testing modalities. Let's move on to our next workshop objective then, to position point of care correctly when in challenging settings. This is necessary because if we use a device, and I'm showing you one which is in slide 28, that potentially in the future, as it gets down the commercial pipeline, will provide automated PCR-based testing for influenza and antiviral resistance testing in a point-of-care platform that really can be packaged smaller than what I'm showing you, which is maybe the size of 2 toasters, but very needed to deal with influenza and other new threats. The next slide summarizes the current state of affairs for H7N9, which is not as threatening as the SARS-like virus that's out there, which has a higher morbidity rate and mortality rate, with 22 out of 33 known cases dead. And nonetheless, should we see this kind of threat develop, a key feature will be isolation. So in slide 30, we're going to turn back to the alternate care facility that we have presented earlier and propose that it be used as a site to potentially isolate these patients that may be subject to pandemics, but then as well to organize and isolate patients that are in a variety of natural disasters. And I would just like to ask you, with this sort of design, what is missing? That question is relatively straightforward. In slide 31, of course, point of care testing is missing. So now we're going to make replete with a variety of devices the alternate care facility so that it can be a center for evidence-based triage, evidence-based monitoring and diagnosis, and to the extent possible, also therapy. On the left, we've listed the main functional modalities that could occur here, such as isolating patients that have documented influenza infections, which are threatening, and then dealing also in the disaster setting with bloodstream infections, technology that might not be readily available in some low resource settings, such as whole blood analyzers for electrolytes and blood gases, and even blood donor screening, which is one of the technologies that our center has promoted. And by the way, the automated PCR-based platform is a product of the ingenuity of Dr. Kelso at Northwestern University and his colleagues, and is one of the other projects in the commercial pipeline that have resulted from NIH funding for our center. Our 5th workshop objective is to develop an enduring guidelines and policy framework for the future in order to accelerate global harmonization. Well, indeed, this is a big project, but in the long run it will be worth it to all people and countries involved. And to be fair, I must warn you that there is a fair amount of thinking out loud, but hopefully it will provide inspiration to you to consider what your country is doing, what the status of policy and guidelines for point-of-care testing might be, and then how to integrate disaster caches and indeed appropriate guidelines for emergency and disaster point-of-care testing into national policy. Let's put it in context first with slide 33. We do have an unusual event that occurred in July 2012 when Malaysia, and I was there to help introduce this whole idea. Malaysia introduced a national point-of-care testing policy and guidelines. It uniquely combines policy and guidelines in one product. It is endorsed by the Ministry of Health for all of Malaysia. It is one of the world's first nationally harmonized approaches to point-of-care testing that I know of. While there are others, this one seems to be singularly unique and interesting, and it is a major advantage for cost effectiveness in a low resource setting. The next few slides present some of the structure in the policy and guideline. I won't go into details. This is intended just to give you an impression, if you will, that in fact we could include complex emergency and disaster point-of-care testing in such a national policy and guideline. And by the way, this one does not have that, so it needs to be added. Slide 34 shows you some of the leadership structure and the idea of seamless harmonization throughout Malaysia. Slide 35 shows you some of the governing committees, how this will actually have a motor that makes the whole product run. And then slide 36 shows you the involvement of various health departments and the actual Small World Network personnel and organizations that would be involved in implementation. So I think that Malaysia has been quite ambitious and brave in introducing this sort of concept at a nationwide level. And bear in mind that Malaysia is a complex geography with a separate island nation separated out to the east. And therefore, while it is a challenge, it is certainly of high merit to have a uniform approach to point-of-care testing throughout the country. Then recently, in the last month, as shown in slide 37, I was in Brazil. I don't expect you to be able to read this because it's in Portuguese, and I don't have an English translation yet, but it shows you yet again another national guideline for point-of-care testing. Moving on then, I'll show you what we're doing in the United States, but it's not intended to be parochial to the United States just for our country, but instead a global guideline, and it is the one listed at the very bottom, POCT 15, Emergency and Disaster Point of Care Testing, which I am co-chairing with Dr. Jim Nichols to produce a Clinical and Laboratory Standards Institute document. In regard to this particular product, it is on the verge of being issued for public comment, and when it hits the public domain, I certainly hope you will reflect on these lectures, reflect on your own national needs, critique the document, provide us with lots of feedback, great ideas, and approaches that will help us globally harmonize not just disaster caches, but the entire set of operating principles by which they are used. In this lecture then, I will conclude with a recommended strategic roadmap that we feel will improve and harmonize point-of-care national and global disaster caches. So in other words, we have focused down on the supplies, the actual armamentarium that's available to implement should we end up in a few years with some sort of a global harmony in the terms of the policy and guidelines that we see. But at this point, we've been relatively conservative. And now in the next slide 40, I'll show you what we think is that framework. On the left, we see national and global leadership formulating strategic plans for point-of-care testing with an implementation timeline, funding, and policy realities along with harmonization, at least at the national level. In the first lecture, we talked about the importance of needs assessment that you see at the top left. And from needs assessment, where we survey users, select devices and tests, guide our point-of-care inventors and innovators, that is the R&D developers, and also develop hospital requirements at the same time for cost effectiveness. We will feed that forward to standard operating procedures, such as you see listed in the middle left, that include test principles and step-by-step procedures. For example, limitations, principles of reagent storage that we've talked about under the category of environmental stress testing, and how to protect from high temperature, high humidity, and in the case of cold disasters, likewise how to keep reagents in the appropriate, fairly nice ambient that they want to see. We have made a split here after validating these tests, which we feel must be a central function, into non-wave testing and clear wave testing. In the simplest possible common denominator, clear wave tests, you must simply follow the manufacturer's instructions, which have been approved in the form of the package insert by our Food and Drug Administration, or FDA. More complicated validation procedures are in order for non-wave testing. And through the left cycle then, our national leadership can impact global leadership and push us forward to appropriate written competency plans that you see center right, where we describe test principles, operating manuals are written. We describe limitations. We discuss confounding factors and interferences and put a package together that people can use at a practical level in order to operate the devices. It probably is not enough nowadays if we want to achieve harmonization that we would attempt to do this through written products. We must go to the web. So we have also proposed an online education and knowledge center for disaster point of care. I think the time is both right and needed to do this sort of central world education, if you will. And we have started with YouTube, where you will actually find these lectures in due course. And we feel that additionally, some of this education can be delivered along with the devices in a cache-based system that has Wi-Fi connectivity. And of course, it needs to be delivered in the correct language for a particular country. The advantage of having a cloud concept for education, beside from the obvious ubiquitousness and general accessibility of that, and again, that should be free, as I mentioned earlier. The additional advantage is that this can be accessed just in time, and by that we mean grabbing instructions, understanding cache resources, and tuning up point-of-care coordinator and operator wherever they happen to be as located by our geographic information system. At the same time, the kernel of the whole operation will be highly competent and trained operators. You see at the bottom middle of the roadmap. And for such training, we have identified both CLIA-waived and non-waived testing and listed several of the attributes of each. It's not enough to train once, so we have a wing of this where the operator is recertified, retrained, and refreshed annually. And only these people will be allowed to use the disaster cache in actual field settings, so that we don't run into a trap of producing unnecessary errors and misinformation. Finally, on the right, we end up with the actual deployment, the actual field use, and we need to go through a checklist, and we haven't put everything in this box, but instead list some of the most critical features for field use, such as establishing the min-max temperature to which the reagents have been exposed, doing quality control first before actual victim or patient testing, maintaining suitable environmental conditions, and here we have to be very clever about it. We'd love to have more robust reagents, perhaps packaged in special foil containment. We'd also at the same time like to put those in small thermomodulation boxes to protect them, and then once in the field, we would like to see many of these resources used in the alternate care facility where there's a better opportunity to control environmental conditions. Well, in the field, we're going to do victim testing, and we're going to enable these ancillary care facilities for triage and other critical functions. And I thank you very much for your attention today. I'll close with 3 slides that present you with the current state coming this summer to Houston, Texas at the annual national and international meeting of AACC, the American Association for Clinical Chemistry, where there will be August 1st a critical and point-of-care testing forum titled The Role of Point-of-Care Testing in a Disaster Plan. Additionally, we have people, as you see slide 42 portraying, who had real grassroots experience and still do with the Haiti earthquake. And in the last slide, 43, there will be a session on July 29th in the afternoon, chaired by Sarah Brown, who is one of the individuals with the Haiti experience, titled Clinical Chemistry and Disaster Response in Resource-Poor Environments. I want to invite all of you personally to come and hear my talk. It will be titled The Use of Small World Networks and Technological Advances in Point of Care for Disaster Preparedness, Response, and Resilience. And hopefully before July 29th, I'll hear from many of you. You'll have a chance to think about this workshop concept, a chance to contribute to our ideas of the disaster cache, and then very, very importantly, a chance to critique the CLSI guideline POCT 15, emergency and disaster point of care testing when it appears in the public domain. Thank you again for your attention, enthusiasm, and thanks in advance for your future contributions. Have a good day.